let's go ahead with the clinical implementation of the glycemic pentad and the role of triple drug therapy in management of diabetes patient. So going straight to the talk, we have a glycemic pentad, glycemic variability, quality of life, glycemic pentad management in terms of diet, the AGIs, role of triple drug and a fixed dose combination, AGI versus gliptin, and conclusion. So let's look at pentad. What does it mean? It looks at three aspects, which is actually A1C, fasting sugar, and a prandial sugar, which talks about efficacy of a drug therapy. When you look at glycemic variability and quality of life, it looks at safety. So its efficacy and safety all put together makes it glycemic pentad. In fact, you can think one step ahead and make it SEXAD, in which you have a nocturnal hypoglycemia, which is also an important aspect which can cause death in the bed syndrome. So therefore, these are the important aspects of management of diabetes. You are not satisfied with only three aspects like A1C, fasting, and prandial. You have to extend the two more benefits to the patient when you treat diabetes. So the variability is very important because the A1C and the blood sugar testing will not address this change. You can see on top the high glucose, and you can see sometimes it's dipping down into a phase of hypoglycemia, and therefore this kind of a change that you see in blood sugar, like this trough and valley becomes peaks and valley, are important, which are not picked up by either SMBG or by fasting and prandial blood sugar. And these are the two examples. We'll look at the A1C of 8% in both the individuals. In the A patient, you can see the valley and the peaks which are there, and there were a lot of fluctuation in the blood sugar, and the lower person has also equally same A1C, but the fluctuations are well less. So person who is at lower panel is much more safer than the patient on the top panel because the fluctuations in blood sugar are more in the top panel compared to lower panel. So therefore, it's a retrospective analysis using continuous glucose monitoring data in 70,000 patients of type 2 diabetes. So it's discussed in the 9th International Conference on the Advanced Technologies and Treatment. And those patients who experience high rates of glycemic variability, hypoglycemia and hyperglycemia, regardless whether they manage their diabetes with diet and exercise and medication or insulin. So the entire concept of variability came after a DCCT study. When they looked at DCCT study, they saw two cohorts, one with the intensive treatment, the other with the conventional treatment. And when they followed these patients subsequently, what they noticed, those with the intensive treatment group, at the end, even if the A1C is high, at the end of the study, they have a less retinopathy compared to those in conventional treatment. So this difference in retinopathy in these two individuals, though both have a similar A1C, one who received the previously intensive, the other one did not, was probably labeled because of variability. That's how the concept of variability came into thought. Then subsequently realized this entire presentation by DCCT was totally, absolutely wrong because this was the statistical error. The entire data was retracted from the public domain, and they said we are wrong. We made a mistake in saying that this is what happened. That's how the birth of variability came into picture. And if you look at the MAGE, which means the mean amplitude of glycemic excursion, and if you look at the cardiac event in these patients, it shows the hazard ratio of 2.62, suggesting that this kind of a MAGE is responsible for the cardiovascular events. Besides that, we have smoking and the male sex, hyperlipidemia, other factors which also are responsible for increased cardiovascular events. So the importance of visit to glycemic variability is also important. This is the study advanced trial, which looked at visit to visit variability of A1C. And it realized if the more the variability, the hazard ratio of 1.64, the 64% more incidence of ischemic events was responsible in these patients who had visit-to-visit variability in the A1C in the advanced study. So therefore, the large body of evidence of a glycemic variability implication says that the pre- and postprandial blood glucose, the mean blood glucose were significantly related to cardiovascular disease. This is per DCCT study. And the Verona study again looks at saying that glucose variability has a greater effect on survival, and the diabetes outcome studies also said that the risk of hypoglycemia as much as related to glucose variability to the mean blood glucose. In other words, the glycemic variability is actually a risk factor for coronary artery disease. This is the very important aspect, which was first proposed by Lee Monnier from France. And what he looked at you have two parameters at each test. There is a fasting sugar and a prandial sugar, and that decides what is the A1C. So that's the vector which tells us what are the possible complications when you estimate A1C in these patients. But what is more important is when you look at the mean amplitude excursions, and when you look at these excursions, it acts as extra dimension, and that makes the cube. And this is responsible for a classical parameters of glucose control and acute glucose fluctuations in the development of complications. And therefore, excessive glycation and a generation of oxidative stress and the glucose fluctuations are because of this variability of blood sugar in these patients. Now, that's why if you look at these two patients, one who has variability on the top panel and the other one which has also sustained hyperglycemia, the one with variability has a more endothelial damage with every surge of the blood sugar which hits on the endothelium, producing the endothelial damage and therefore resulting into the complications, namely the cardiovascular complications. Now, this is a very interesting study. It was done in Japan in about 70-year-old patients. They picked up 65 patients who are non-diabetic, and these patients were having coronary artery disease, and they were planned to do an angiography and angioplasty. And before that, they had undergone 48 hours glucose monitoring system. And they divided these patients based on the MAGE, those who had the MAGE below 65 and those who had MAGE above 65. And what they said, that those who had MAGE below 65% had 11.8% cardiovascular mortality, and versus those who are above 65 had almost about 27% cardiovascular mortality with a significant p-value, suggesting the blood sugar variation, even in non-diabetic patients, contributes to the ischemic events, which is a very important observation. And this was studied for a period of 1 year, and they realized, even the right hand of the graph, that over a period of 1 year, this problem can last as a part of glycemic variability, which is a very important study. The quality of life was discussed by great length by Dr. S.R. Arvind, the great speaker, very humorous talk, and he's mentioned about this definition of quality of life. It's a multidimensional construct incorporating an individual's subjective perception of physical, emotional, social well-being. Whenever I go to psychiatrists, they always speak such language called jargon of words. It's very nice to listen to that. When we want to interpret it, you can't understand what they're saying. So it's all Greek and Latin when you want to interpret the language, but anyway, it sounds nice. It looks nice. Somebody is talking something big, and something very big words have been used. It includes both the cognitive component and the emotional component. Both are important, and that gives happiness. The emotion gives you happiness. The dopamine in the brain gives you happiness. That's reward. Dr. Arvind was talking of reward, and that's the release of dopamine in the brain, and that gives happiness. So therefore, the quality of life in patients of diabetes is impaired because of poor glycemic control, because the complication of diabetes due to poor control, the anxiety and depression. When I think of future, they think they get anxiety. When they think of past, they become depressed. There's a polyneuropathy and muscle strength which makes them incapable of walking, balancing, tend to fall. Sleep disturbances are very common, again because of change of neurotransmitters in the brain, and a cognitive impairment is also very common. That's called diabetic dementia. And therefore, the poor quality of life prevents the self-care, worsens the glycemic control, increases the complication that further worsens the quality of life, and that predicts the individual capacity to manage the disease and maintain the long-term health and well-being. So therefore, Indian patients have a peculiar dilemma. The monotherapy might not address all the 5 aspects of glycemic pentad, distinct dietary habits, socioeconomic status, and the quality of life is not addressed. So let's look at the diet, which is very important. In fact, the Mary Matilda has said that it is very easy to change religion, but not your diet. So it's very difficult for people to change their habits, but still we need to intensify Efforts to make the patient diet compliant, which requires education, the awareness, the peer pressure groups, the education of caregivers is also important. And of course, the diet habits modification and a substitution of a low glycemic food is also important. This is a very important study. It was published in 2008, and there were patients, these are actually healthy volunteers from Oxford, England, and about 13 people from South India, Chennai. And what they looked at, they were all young people, healthy people, they have no disease whatsoever. They have given these 5 kinds of food, and subsequently they checked the capillary blood at the interval of half an hour, 1 hour, 1.5 hours, and 2 hours. And what they saw, that in Indian patients, the glycemic response is much higher than what you see in the Caucasians, suggesting that we have more insulin resistance. That's why disposal of glucose to the glucose-sensitive tissue is quite less, and therefore a response for the postprandial hyperglycemia is quite severe, though the glycemic index and the body build of both the individuals from India and from England are identical. So therefore, the management requires a drug which controls the prandial sugar, and the alpha-glycosidase inhibitor works extremely well in this, and it controls the post-meal hyperglycemia. And since it's difficult for the patient to plan the carbohydrate intake based on the insulin dose alone, and therefore it is very important to use this molecule, and voglibose could decrease both glycemic variability by controlling the prandial sugar, and there is no risk of hypoglycemia that you get in short-acting insulins in these patients. So this was a study, head-to-head analysis, which looked at 90 patients of type 2 diabetes with their inclusion criteria was blood sugar more than 200 and glycated hemoglobin more than 7% at the first visit. They were either randomized to take miglitol, acarbose, and voglibose, and they evaluated at 3 months later. And what you see here, amongst all the 3 molecules, the voglibose has the highest reduction of the postprandial blood sugar, and as compared to any of the molecules. And the adverse reaction in the miglitol group was 5 patients, acarbose was about 10 patients, and 2 patients voglibose. Voglibose well tolerated compared to other drugs. So the conclusion of the study was the present study recommends the use of voglibose, looking at its efficacy, safety, and profile amongst available alpha-glycosidase inhibitors as a preferential choice in the management of prandial hyperglycemia in type 2 diabetes. So this is again a study which looked at the combination of 3 drugs. And these are the patients between 18 to 70 years with the hemoglobin A1C more than 7% for a period of 3 months prior to screening, and the patients with at least 2 prandial excursion of blood sugar more than 140 for a period of 14 days were included in the study. And 101 patients, in which 73 patients were on triple drug combination of metformin, sulfonylurea with voglibose, and 28 patients with metformin and voglibose alone. And there was a significant decrease in the MAGE in the triple drug therapy. The patients with triple drug therapy experienced less glycemic excursion, and there was a significant decrease in the mean PPG area under the curve at day 14 and at night, and the mean glucose fasting sugar also was reduced significantly. So to conclude that this triple drug combination reduces the glycemic variability, and there was no risk of hypoglycemia in these patients. And these glycemic excursions were observed on the Freestyle Libre Pro Flash system. So voglibose in combination therapy, especially in the Indian patients, would effectively control the fasting glucose in the prandial and the A1C, and the overall glycemic variability could also be significantly reduced. It's effective in glycemic variability and A1C in the Indian diabetic patients. The results are significant when data from triple fixed dose combination compared to metformin glimepiride alone, and twice daily dosing of FDC after breakfast and dinner is sufficient to prevent glycemic excursion per day. So therefore, this is another good study which looked at the comparison of voglibose versus sitagliptin. These are about 17 patients who were either given voglibose for a period of 2 months. And after 2 months, they were admitted in the hospital for 4 days, and they did their CGMS. So first, the patient received voglibose. After 2 months, admitted in the hospital. For 4 days, they did CGM. And after that, the patient was readmitted again after taking sitagliptin for about 2 months, and then CGM for about 4 days. What it says, that the time from before meal to the postprandial peak is much longer in patients who took voglibose, suggesting that the peaking of the blood sugar postprandial is far low. And if you compare sitagliptin, it is 91.5. Now, why did it compare with sitagliptin? Because gliptins control 40% of the prandial sugar change. And therefore, they wanted to compare with the drug which is meant for the prandial control. And therefore, they looked at these two combinations. It showed voglibose definitely delayed the peaking. Sitagliptin significantly lowered the 24-hour blood sugar, but the prandial sugar was better controlled by voglibose. And the time from before dinner to the peak postprandial glucose was also significantly longer with voglibose, even at dinner time. And the slope of postprandial evaluation of glucose level was significantly lower after each meal with voglibose compared to gliptin. So to conclude, what I said for, consider the pentad relevance in the Indian patients, especially we have insulin resistance and the prandial hyperglycemia, which is the main driver for the ischemic heart disease. So therefore, this becomes an important consideration when you have patients from India to be treated. Choose drugs and combinations which will address all the aspects of pentad. I remember last year in the month of April, about 556 drugs were banned by the Indian government because of illogical combination therapy. And most of them had multiple drugs which were illogical and irrational. And now we have to consider the rational combination for the right treatment for a patient from India, where we have to address the prandial sugar as a major concern of control for diabetes. Increased use of voglibose-based combination do reduce prandial glucose, and voglibose or all AGIs do not figure in the guidelines of ADA and EASD, because this is not considered because we have 65% of our diet coming from the starch. The starch study, which looked at all the population from the east, west, north, and south, irrespective from where the patient came, 65 to 70% of the food content was carbohydrate, and we need to address that problem also. So therefore, the voglibose therapy is important from that point of view. So judicious use of the drugs and fixed dose combination improve the patient compliance, and therefore this combination should be used, especially in patients who have a prandial hyperglycemia. With that, I thank you very much. So consider the pentad, the three aspects of the efficacy of a drug and two aspects of safety of a drug. So efficacy and safety both combined together makes a pentad therapy for diabetes. With that, thank you very much.